Okay, so I will get started with the first introduction, and I would just like to introduce Dr. Cho. So Dr. Steven Cho practices full scope oral and maxillofacial surgery and has a particular interest in treating dental implant reconstruction, facial trauma patients, and skeletal facial deformities. Dr. Cho is active in organized dentistry and is a fellow of the American Association of Oral and Maxillofacial Surgeons, the American College of Oral and Maxillofacial Surgeons, the New York State Society of Oral and Maxillofacial Surgeons, the American College of Dentists, and the New York Academy of Dentistry. So with that, I'm going to turn it over to Dr. Cho.
Thank you, Michelle. So good evening, everyone. So as you know, I'm the chair of the Education Committee at New York Academy of Dentistry. Thank you for joining us tonight, and welcome to our second joint New York Academy of Dentistry and ASDA event. I am thrilled we have with us wonderful speakers for the evening. Before I turn over the program to Michelle, Abe, and Annalie, who will introduce the speakers, I would like to have Dr. Julie Connolly, President of the New York Academy of Dentistry, say a few words. Julie?
So I'm going to just make an attempt to share my screen here. All right. Is that good? Can we see it? Okay. Thank you. All right. So welcome, everyone. I am the president of the New York Academy of Dentistry, and I'm so excited that we're able to put together our second event with ASDA following the event in the fall on humanitarian outreach. And thank you to Dr. Cho and to Michelle for working so hard to put this together. I know some of you were here in the fall for that meeting, but I just wanted to give a brief introduction to who we are and also just say welcome to all the different ASDA chapters who are here tonight. One of the benefits of being virtual is we can reach so many more students and so many more people. So while I miss seeing all of you in person, this is something we can be grateful for. We can all come together in this format. Now, just a word about the New York Academy of Dentistry. We are currently celebrating our 100th anniversary. Our organization was founded in February of 1921 by local New York dentists who were fairly renowned at the time. And it was 19 dentists, and they were the leadership of our profession in New York City. And they found the need to come together to form an academy that would focus on leadership, on research, on volunteerism, and on ethics. And at that time, this was significant because professional education, scientific publications, ethical standards were still not clearly defined. So this group came together with this purpose. Now, I'm not going to bore you by talking about the details of our bylaws, but I did go through briefly, and from our mission, from our vision, and even from the education committee that Dr. Cho leads, you can get a sense that we are about promoting dental education, dental science, giving lectures to our fellows, and just being very involved with dental students. For many years, we were working hand in hand with many of the local dental schools with their ethics programs. And this lasted from the 90s until about the mid-2010s. The schools now have taken them over on their own. And we're so happy to now have this new relationship with ASDA and to have this second event tonight. Now, if you'd like to learn more about the organization, this is our website. Please visit it. You can learn about many of the different things that we're doing as fellows, our outreach efforts, and our different meetings and speakers. With that, I would like to just also offer some congratulations. I'm heard that last weekend there was a changing of the guard for ASDA, and so Sydney Shapiro is now our immediate national past president of ASDA. Michelle Skeleton is the national vice president of ASDA, so congratulations, Michelle. And Annalie Sorrentino out of Buffalo is our new ASDA District 2 trustee. So congratulations, everyone. And with that, Michelle, thank you.
Thank you so much for the presentation, Dr. Connolly. I'm going to turn it over to Abe to introduce Dr. Jerem.
Sorry. All right. Thank you everyone for joining. So we have Dr. Alan Joram. He's the Director of Digital Dentistry and Clinical Assistant Professor of Dental Medicine at Toro. Dr. Jerome has led the development of the college's robust digital dentistry program, assembling a team of experts to develop an innovative approach to training students using the latest digital dentistry technologies and techniques, including but not limited to, we have CAD/CAM milling, intraoral scanning, 3D printing. Dr. Jerome lectures internationally on digital photography, digital dentistry, CAD/CAM technologies, cosmetic case planning, and complex reconstructive dental treatments. Dr. Jerome's private office has been featured as a model for innovative digital treatments, focusing on comprehensive restorative, implant, and aesthetic dentistry using various digital and CAD/CAM technologies. So with that, Dr. Jerome, you got the mic.
Wonderful. Thank you for that great introduction. I appreciate it. Today, we're going to be discussing and trying to give, in a very condensed period of time, a little bit of the flavor of digital dentistry that we provide and we teach at Toro and we use in our private practices. I'm joined today with Dr. Jay Rubin, who is the Director of Implantology at Toro College of Dental Medicine, and also with Mr. Sunil Abraham, who is one of the technology advisors at the school. And we're part of the team that is capable and in charge of providing some of the most unique dental workflows. And so we're going to end today with sharing some of those unique workflows in our implant dentistry. And I'm really looking forward to sharing with you a little bit about the technology, how the technology really builds upon a strong foundation, and how one of the most important parts to it is how we adapt as the technology changes very, very quickly. And I hope that within the short period of time that we have, that we can generate some interest. We could also generate some really good questions. At the end, we could do a nice Q&A. And from there, we hope to inspire and to educate. A little bit about myself. So I do practice on Long Island with my sister, Dr. Barbara Jerome. Both of us do teach at Toro. And we share a lot of the workflows that we do, both from an office perspective. So we have our dental office in our building. We also have a dental laboratory. And we have a place where we like to share a lot of the dentistry, both from the clinical side and the laboratory side in our academy. And I think it's a really beneficial process. And this is really what we've done at Toro, is to bring all these different technologies under one roof in order for us to demonstrate and best share how technology changes and how we can make the patient care better fundamentally. And at Toro College of Dental Medicine, this has been, the most important part of how we've developed the curriculum and how we have a strong emphasis on technology, because really, as technology is used in our day-to-day lives, we have the same influence in dentistry. And part of what I want to discuss today as well is, how do we use the technology currently and where is it going to be going in the future? And a lot of that has to do with artificial intelligence. So I'm going to hopefully have a couple moments to explain a little bit about how artificial intelligence and dentistry are also really coming together. At Toro, what we've really focused on is developing a lot of the systems for us to be able to take the technology, share it, and give our students, this practical education and experience with it, so that when they do graduate and they are introduced to all of these new parts of dentistry by practicing in their new clinics or their new offices, to make sure that they have that practical experience. And it really is what I find one of the most exciting parts of dentistry these days. So, at Toro, one of the most important things we've developed is a way to take the technology and share it. And a lot of that happens with a lot of these specialized computer systems that we use. And, the college, and as COVID has changed the way we practice and changed the way that we, look at dentistry from a perspective of safety and the importance of patient care, I think the technology also provides a very good avenue for us to enhance the level of patient care and still remain as safe as possible, in the day and age that we all live in. So one of the most important parts of Toro is how we can take, let's say a series, we have 26 Trio scanners at the school, and we have, over 400, students. So we're not going to have 400 students or 400 scanners for 400 students. So part of what we've worked a lot in, how do we take this technology and make it available to everybody within the school's digital ecosystem? And a lot of that happens and begins with the way that our IT infrastructure is set up. So on the left-hand side here, you see this is the dental school. The dental school now on the 3rd and 4th floor are clinical environments and education parts. Right across the way from us is Hudson CIO, and this is where we have the team who helped implement a lot of the technology that we end up using. And what's so great about this is that, right down the street from Hudson is actually an industrial data farm. This is a server farm where companies, Fortune 500 companies, keep their servers, their infrastructure in order to make sure that data is protected and data is accessible. And all of the information that we record from our patients are kept on these special servers. And what's unique about this is that as we created this virtual environment for the students and faculty and everybody in the school environment to be able to use digital dentistry and the tools of digital dentistry, we had to not reinvent, but look from a different perspective of what the computers need in order to provide this. And a lot of that happens with some specialized video cards, which fundamentally mean that we can take a scan on one of the Trio systems. And then once that scan is complete, that scan will be available on any of the virtual machines throughout the school to be used in its full glory in its 3D environment, so that we can use that scan not to just provide treatment, but also to learn and to provide analysis. And that's where artificial intelligence really comes into dentistry. And when we end up today, one of the last parts I want to discuss with artificial intelligence is how all of this information can be used and will be used in future applications. So to take one step back and we talk about digital dentistry, I want to talk to it in 3 different perspectives. There's the inputting of information, the processing of that information, and then outputting. Now, for example, like Abe said, at the dental school, we have DG-shaped milling machines. So for same-day workflows, if we are going to scan a patient, that's part of the input process. That's how we're going to capture data. And so we capture data from different realms. The processing is most common in dentistry for us to be able to design a restoration, or a laboratory to design a restoration. And that's been changing a lot, especially with artificial intelligence. And then how do we output? What are the output systems in digital dentistry? Well, there's 3D printers, there's milling systems. And so we're going to hit upon all of these briefly, all these different tools that are available that fundamentally are really should be used to increase the level of patient care that we can give. We shouldn't do digital dentistry just to say that we're digital and this is the hottest new tool that's on the market. It really needs to have a practical application in making patient care better. And that's where we've had the most excitement and the most results with it. So if we look at some of the input systems, we have intraoral scanners, we have SLR cameras, we have 3D X-ray machines. We even use the device you see on the bottom there that looks like Wally, which is photogrammetry, which we use in order to record very accurate full arch digital implant impressions. So once we've captured all of this data, well, how do we process it? And what are the processing tools? Well, like I said before, we use it for design. And what's really a trend that we're beginning to embrace and see the value in is once we have all of this data of our patients, we have Trio scans now for 4 years of patients who've been in the clinic of the school. A new student who joins the environment can look back in time and see this patient's mouth and their oral environment and all the different scans and almost play them like a video that you could begin to visually see the changes that have happened with this patient over the past 4 years. And so that really lends itself to improving how we could diagnose and how we could analyze our patients. A lot of the ecosystem that we use is based off 3Shapes technology. And what's really interesting about this part is that the students have access to both the clinical software, the software that's really capture most of the data, and also the laboratory software, which is really used to do the digital design. When we talk about the output, different systems, but really there's 3 main ways in digital dentistry that we can output information. And probably the oldest and most common was with milling machines, like you see here on the right-hand side. And recently, we've also had massive improvements in 3D printing in dentistry. In fact, dentistry is one of the environments that has adopted 3D printing more so than other industries because of all of the really wonderful indications that are very applicable in dentistry to use 3D printing in. And another output that's often overlooked is what we see here, which are just monitors. Just the ability to take different information, scans of different periods of time, and align those scans and to view that alignment and then to learn, for example, let's say that this tooth is shifted, or let's say we can see how this tooth is worn down over time. That's really one of the wonderful applications of digital dentistry. And so just a screen is a very valuable output device. Talking about the mills, so we have these really big milling machines, 5-axis mills, very technically complex to be used, and they've shrunk over time. And with that, it makes the technology more accessible to the end user. So a lot of these really big milling machines now have shrunk down in size, and they still provide a very, very detailed level of accuracy that opens up indications and workflows that just really weren't available before. Like you see here on the left, provisional crowns. Provisional crowns that are made digitally are really prototypes. They're not really temporaries, and you have to think of them in that way. They're going to fit as a final crown would fit. So a lot of times it's a very useful appliance to use if we, let's say, are going to be doing a periodontal surgery and we want the gum tissue to heal as well as possible. Implant restoration, same-day onlays, inlays, all of these are really at a level that we haven't seen before in dentistry, and at a price point that is really, really improving the quality of care that we're providing. And 3D printing as well. 3D printing is an additive process. Instead of taking a block of material and cutting it away, we build. And what it really allows us to do is take very complex appliances and easily manufacture them. For example, surgical guides, like you see here on the left, that's an implant surgical guide. And you know, in the school environment, we first adopted 3D printing to produce surgical guides in the school environment. And Sunny at the school is the one who does and manages most of the printers at the school. And later on in this presentation and towards the end, when Dr. Rubin takes over, we're going to discuss on how we use these printers for both the applications of creating surgical guides and how we use it to produce immediate prototype full arch implant restorations for our patients. You know, one of the other really wonderful parts of 3D printing is how we use it on cosmetic cases. So a case like this where you see from left to right and how we start with the pre-op situation, we do a 2D digital smile design, we generate a 3D diagnostic wax up that could then be printed. We call them a digital tooth setup, and that can help influence the steps of a case to make sure we end up with a very nice predictable outcome. So when we're talking about 3D printing and technology, one of the first steps that we're going to use is a lot of the input data that we acquired in order to create, in an example like this, what we call our digital tooth setup. So we start with the photography and the trio scans, and those can all get aligned. And once they're aligned, it allows us to do a patient-specific digital tooth setup. If you see here, I'm actually designing this patient's smile directly in their dentofacial profile. And we can go ahead and produce a very, very accurate proposal, digital wax up, or even a design of, you know, any other dental indication. And this could be done directly in the patient's face. A really wonderful part. Again, digital dentistry is all about aligning different data sets. So once we've produced this patient-specific digital tooth setup, we can then take this and we can send this off to one of the 3D printers. Here you can see where we've added material. And once this has been printed on one of the 3D printers, we can actually take this and transfer it to the mouth. So what you see there is it actually printed, and then we make a quick suck down on top of that. And we could transfer it to the mouth, and we can test drive before we've ever actually done anything permanent to the patient. And trying to use this approach of working in reverse. We want to first, before we do anything permanent to a patient, before we ever touch the patient with a handpiece, we want to get as much information to help dictate how we should maybe prepare the teeth or how we should treatment plan the case. And technology allows us to do that, to work in reverse. And that's going to be probably explained the best or demonstrated the best when we show a little bit of our workflow for our full arch implant cases. So from here, we would take this mock-up, we would take more photos, and we would use that to help influence our plan and our proposed series of steps to end up with a very predictable, nice final outcome. 3D printing and milling, when combined, I like to say really add to our digital dental toolbox, to what we are able to produce for our patients with a very high level of precision, and also to leverage some of the other parts of digital dentistry, for example, reproducibility. And so let's take a little bit look further at some of the other parts of the imaging ecosystem and specifically talk some more about intraoral scanning. And I want to discuss intraoral scanning now because what I found is that intraoral scanning is probably one of the most influential steps into joining digital dentistry. In fact, most people begin their digital journey with acquiring an intraoral scanner, even though photography has been out longer, even though there's been other aspects of digital dentistry. Intraoral scanning really is one of the most important tools into taking that step into technology. And we've always used it for a restorative process. And where it's really beginning to shine, especially when we talk about applications like artificial intelligence, is how we could use it for this diagnostic approach now, how we can use it to kind of look beyond what's visible and how we can use it to help influence our decision-making process for that patient's care. And so one of these concepts that's here, every patient, every time, really sums up the best way I could describe on what is the most important information to capture on that patient so that we have this digital patient library built and we can use all of this digital information now and well within the future to help influence our judgment and our treatment planning. So we talk about intraoral scanning and a lot of the different solutions that are out there. There's standalone solutions, mobile ones, but fundamentally scanning builds our digital patient library. And AI scanning is one of the really most exciting parts of where scanning is moving towards to really make that process as easy as possible. Now, in my private office, we've actually set up a Trio scan room. This is a room where there's a scanner that's built into the chair. And this room is really set up for us to capture that information as easy as possible. When I mean ease, what I'm talking about is we don't have to set the scanner up. The scanner is built into the chair. It's a process where we can easily capture this information on all of our new patients and all of our existing patients. Every patient receives a scan at least once a year to help build that digital patient library. And as we build the digital patient library and we produce these very high resolution digital scans of our patients and their oral environment, this information doesn't change over time. So there's a tremendous amount of value that we find with this. So another one of the important parts of intraoral scanning is, do you use a laptop to scan or do you use a high-end gaming computer? And what we've learned at the dental school is that as we wanted to really implement artificial intelligence scanning, which really does use a lot of horsepower, we've implemented and used special computers that we designed and put in place that allow us to capture the information with a very good scanning experience. Meaning we don't want it to lag, we want it to capture very well, because artificial intelligence in the scanning is a very data intensive process. And I'm going to share with you in a little bit of just what actual artificial intelligence scanning is. But what it's really allowing us to do is capture information without having to go ahead and have a steep learning curve in how we take our intraoral scans. So if we look in this video here on the right-hand side, we have the artificial intelligence scanning feature on, and on the left-hand side, it's off. Now, what it truly means is artificial intelligence in scanning means the software, the system, the scanner can actually ask itself a question and answer it. Is the information that I just recorded desirable structures or undesirable structures? And if it's undesirable, it will filter that information out in real time. And that process fundamentally means we can build a scan with having less undesirable information. So we see here, as we're scanning on the left-hand side, you can see all the extra information. For example, the tongue was scanned, the lips, patient or the operator's finger. And artificial AI scanning allows us to filter that information in real time. There's also these other applications of once we've captured all this data on how we can use it for teledentistry. So with the scanning systems, and putting a camera in the right place at the right time, it allows us to go ahead and to take a workflow like we see here, the scanning workflow for a tooth-borne restoration, where we're going to go through all of these different steps. And all these steps are going to happen chairside. Well, if there is support that's necessary or learning, with teledentistry and technology, we have the ability to immediately connect and to help support remotely a lot of the workflows so that the dentistry and the quality of the dentistry follows the level that we want to produce for our patients. But all of these scanning systems, whether it's inside your office or it's outside your office, produces data, right? These scans are digital, and the digital scans won't change over time. And if you think about that, so right now, intraoral scanning, I've been scanning all of our patients since 2012. In 20 years from now, the scans that I took 10 years ago, 9 years ago now are still going to be the same exact level of quality and the same amount of information within there. And all of this data then becomes the food for artificial intelligence. Now, artificial intelligence in itself is really computer systems that begin to analyze a tremendous amount of information, of data, and find patterns within that data. And the ability to find patterns within that data then really means that the computers and the systems can begin asking themselves questions and answering those questions for them. And we see artificial intelligence in the backgrounds today. And most people don't even realize that most of the systems that you're using on a daily basis, Amazon Alexa, Siri, a lot of the AI assistants, and all of the major platforms are all using artificial intelligence to analyze a tremendous amount of data, find the patterns within that data to then propose a solution that may be, directed to a specific task. So for example, in a Tesla, the ability to process massive amounts of data and to learn from that data is allowing their self-driving vehicles to learn at an exponential rate and to use that information to then propose solutions for, in this case, a driving situation. And this is going to be a massive, massive change in our day-to-day lives and in the safety that we can provide in an automobile because of the ability of these systems to root through a ton of data, learn patterns, and use that information to provide different solutions that we never had in the past. In fact, the original computer was this guy, right? The learning CPU, a neural net processor. They could have done much better with his occlusion, though. I gave him a class 3 skeletal relationship here. But here's an example. Now, what you see on the left-hand side is a scan, a CT scan of a patient that was actually taken in 1991. And in 1991, that was the absolute pinnacle of resolution that was available. And what they've done now is they've taken that information from 30 years ago and applied new algorithms and artificial intelligence to review that data and to begin showing information that was there but wasn't readily available just by looking. So you can see the amount of detail and resolution of the information that's on the right, which is all extrapolated through artificial intelligence. And it's really one of the most exciting parts in medicine because, like I said, our digital patient libraries that we're building today are going to be tremendously valuable now and in the future. What we see here is augmented reality, which is artificial intelligence being used to help show information within digital data that's been captured. And where I think this is going to shine even more in the future is the ability for the software to be able to help predict what is going to be most likely happening within the future. So the digital patient library begins to feed artificial intelligence. And for example, one of the tools of artificial intelligence is digital patient monitoring. So I'm going to give a quick example here of digital patient monitoring. And then we're going to end by sharing just a little bit of our full arch implant dentistry with Dr. Rubin and how we apply that technology even further. So this patient had come to me back in 2014. And in 2014, we put together a treatment plan and we did a couple of crowns on the maxillary arch. She was very happy and I didn't see her for many years. And then in 2019, I got a phone call from her saying, actually she called my office manager and was very upset, said that everything has changed. It looks terrible. I need to come in immediately. And I was with another patient. And so I told her, I said, you know what, have her come in. Let's take an intraoral scan. Let me take the intraoral scan from today and compare it to the scan from back when we finished the case in 2014. And let me begin to analyze and teach myself so that I could then in return come back to the patient and say, either validate that yes, something has changed, or, let's see what's actually going on here. So, we have scans of the patient throughout time, right, from 2014 and 2019. And sure enough, I can take a look in the mouth and I can see, yes, look here between number 9 and 10, and I can see that there's a space, a diastema that's opened. And so trying to determine what's going on, and maybe did the centrals move or is it just the lateral? So we take our new trio scan. Now remember, digital patient library means that we have all these other scans available. We have the initial pre-op scan from 2014. We have the scan from when we prepared the teeth. We have the scan of the provisionals. We also have a scan from a crown that we had made on a different area in 2015. And we have our scan from 2019. And all this information can get aligned. And one of the first tools is artificial intelligence, which has been used to segment the scan. So we have all these different scans, and what you see in blue here is artificial intelligence, which has been applied to the scan through 3Shapes system to help determine what is a tooth and what tooth that is in the mouth. And what it means is that we could use it to do tooth by tooth comparisons, and we can also do full arch comparisons. So artificial intelligence is first going to segment these scans and determine this is tooth number 11, 12, 13, and 14 here. And then we can move forward into our analysis. So what we see here in blue is the scan from 2019, and what's in color is the scan from 2014. And if I take this information, I can see that, something looks like it's happening on the lateral. So if I draw a slice, a 2D slice through the 3D model and zoom in here, I can see, again, blue is 2019 and the tan is 2014. And I can see that the tooth has been bodily shifted by 1/4 millimeter here. And that begins to tell me, okay, this is not something that was, let's say, wear. This looks like the tooth has been physically pushed forward. I could also do another analysis because the patient was very concerned that the centrals had also drastically changed since we had delivered them. And so we put another cross section through the centrals, and we could begin to do an analysis and see, all right, in this area, the centrals really don't show much change. In fact, if we zoom in here, we can see that we have about 0.09 millimeters of change in the incisal edge from 2014 to 2019. So this is a very good tool to begin teaching me so that I could then come back, find a solution, and then in return, teach the patient as well. In fact, by looking here and looking at the heat map analysis or the change, what we see here in number 10, I can then come back and it showed me, okay, I can see the wear that's happening on the facial number 22. And it looks like, yes, 22 has pushed the tooth forward. And I have a better idea of what happened and then how to solve it and how to present it to the patient. And what we do here, we made a couple of clear aligners to help bring the tooth back into position, do an occlusal adjustment, and we delivered a special occlusal guard for the patient to wear in the evening time. So again, when we're talking about digital dentistry and the definition of digital dentistry from this perspective of inputting information, processing the information, and outputting it, it's the way that we link these different parts that define our workflows. And one of the most exciting workflows is on how we provide our immediate full arch implant cases. So for example, here, as we go through a case for this patient, we are first going to begin with our preoperative records. We start with digital photography. And then from there, we use the digital photography aligned with the trio scans to go ahead and provide our digital tooth setup. We use that for surgical implant planning. And this is what Dr. Rubin is going to touch on shortly. And we plan the implants relative to where the teeth need to be or where the teeth should end up. So this is how we want to do a great example of us working in reverse. First, determine where the final ideal tooth should be, and then plan everything relative to that. Plan the implants relative to that. Now we can virtually go ahead and provide our implant part acquisition. What parts do we need for the case? The day of the surgery, the teeth are removed, the implants are placed, the implant strength is verified, and then we record the patient immediately after the surgery is complete. And then we can go ahead and we do a design of a prototype restoration. And the prototype restoration is then delivered to the patient within 24 to 48 hours. And months down the road, it takes us one visit to then record how the patient is healed and to use that to develop the final prosthesis that's going to go to the patient. And this has really been one of the most exciting parts, is how we take all these different parts of the digital workflows, from inputting, processing, and outputting, and combining all those together to provide better patient care that's more precise, that is safer for the patient, and fundamentally should allow for a restoration that's going to last longer for that patient. This bridge that's on the screen here is actually one of the prototype bridges we delivered for one of our patients months ago. And so I want to turn it over now to Dr. Rubin, where he's going to discuss a little bit more about how we use technology in the implantology division of Toro.
Thank you, Dr. Alan Germ, Dr. Steve Cho. My position at Toro is I'm the director of implant dentistry. And the first lecture that I give is I put a picture up of a tooth and I put an implant in the middle of it. And I tell the students that the most important thing to understand, and especially at Toro, is that we believe in implant dentistry. I'm a board certified periodontist in private practice with 2 other board certified periodontists. But at Toro, I'm part of a team. I'm part of the team that involves implant dentistry. And it begins with people like Dr. Cho, who's an oral surgeon, Dr. Germ, Dr. Barbara and Alan Germ, who are directors of digital dentistry and complex dentistry, other periodontics. And one of the advantages of our relationship is that we can work together to basically provide the best care for patients, because they don't come in wanting to have implants, to have screws put in or teeth. They want implant dentistry. And so the unique educational experience that we offer to our students at Toro is the synergy of all these specialists working together to create this kind of technology. And when Brandemark originally did his original studies on implant dentistry, he was a Swedish orthopedic surgeon who investigated the use of dental implants to treat crippled dental patients who were totally edentulous, who could not wear their prosthesis. They were totally edentulous, and he developed this protocol based on the process of what he determined the terminology called osseointegration. He had studied rabbit femur chambers with various kinds of metals for orthopedic application. What he found out is that when he went to remove or reverse torque the titanium chamber, he could not remove it from the bone. And he studied it under a light microscopic analysis, and he defined the term osseointegration, where there's a fusion of a metal, in his case titanium, to living bone without a juxtaposition connective tissue. And he applied this through orthopedic principles to totally edentulism patients to create implants. And he studied from 1965 till 1980 over 2,000 implants. And what he was able to determine is that patients could be functionally treated with the process of placement of implants and restoring their full arch with a specific protocol. So originally, implant dentistry was a surgical endeavor. We first wanted to find out that whether it worked or not. And he applied orthopedic OR principles towards this dentistry. The original people who were trained in implant dentistry were only surgeons, not anyone else. And the original people who designed these prototype bridges that Brandemark used were prosthodontists. It was not to the general public. As the 1990s, after the University of Toronto conference where he presented his paper, implant dentistry took off. And it became, over a period of time, prosthetically driven dentistry. And what happened is that we started applying that technology to immediate single teeth, bridge works, partial edentulism, removable partial dentures, overdentures, orthopedic replacements, ocular replacements. Osseointegration became a prosthetically driven endeavor. I would venture to say now that has changed. And I would say that implant dentistry today is digitally driven. And the reason being is that the amount of information that one can acquire from using a scanning process to create an intraoral STL file for the patient and using that technology with cone beam CAT scans, because originally we could only get CAT scans done by sending out a large report to a radiologist and getting back films that over a period of time filled my office with stacks and stacks of films. But now, with the use of limited field cone beam CAT scans and the easy accessibility, cone beam technology has become the standard of care for implant dentistry. And using those two technologies, using the DICOM data from the CAT scans and the STL files from the scanners, we're able to create digital workflows, which is what is the present of digital dentistry, the future of digital dentistry, but it's also only the infancy of digital dentistry, because we could literally say that none of us can say what we did 20 years ago is the same as what we're doing today. The basic science has not changed. Basic science gives us the ability to look at these technologies and what is scientific-based evidence that we can comfortably trust to use on our patients. But the technology is always changing. And if you don't have the basic principles, which is what we believe in, then you can't take that new technology information and apply it to your patient care. So I think that's really important to understand where we're going. What we're involved with in TCDM is this protocol for full arch technology. And what the implant dentistry, the digital technology team in combination with the surgery team, because we work together. Steve is not only my lunch buddy, he's also my colleague. And when I have questions, I go ask him. When he has questions, maybe he'll ask me, okay? I hope he'll ask me. But the ability of the synergy of us to work together at Turo has created a unique educational experience for our students. And I'm sinful to say, is enjoyable for us. It's fun coming to TCDM. Yes, we want to torture the students, but we also want to educate them. But we enjoy each other's knowledge and what we gain from each other's experiences. And that only benefits the students and our patient care. And one of the things that Alan was touching on about the scanning process is what I've learned from my scanner in my office is I've learned how much I didn't know I was missing. Okay, you realize from digital dentistry what you never saw before, okay? And that makes you a bit humble, but also a much better practitioner, okay? And a much better educator, okay? Because you become humble in front of what you didn't see. And so that's one of the great things about digital dentistry. But the protocols that we're doing now, Alan, if you want to put it up, we can put it up and show, I'll discuss what we've done with our digital dentistry team in how to create this. So as we're saying, the original studies were, surgically driven, then it became prosthetically driven. Now I would say it's digitally driven, because what we can do is we can look at the final prototype bridge that's designed in combination with and when I say surgeon, for us, Steve and I, we look at as this working together. I don't differentiate or delineate between periodontist and oral surgeons. Okay, unless we determine who can take out a tooth faster, but we work together because ultimately our surgical procedures, anyone who takes up a scalpel and goes from the realm of treating the patient, we all work together. Okay, so with this digital protocol that we're doing now, we've created the final digital setup first. Okay. And then we look how we can approach it from a surgical standpoint. Do we need to have a resective component? Do we need to reduce the ridge? Because we all know that you need 14 to 18 millimeters for this kind of interocclusal distance to create this kind of prosthetic design. So are we first going to be doing a resective procedure? Do we need to create a reduction guide? Do we need to level the ridge? Are we need to do an additive procedure? Do we need to add bone? Do we need to add soft tissue? Do we need to add both? What is your definitive surgical protocol? Are we going to do a sinus lift? Are we going to use like an all-on-4? We're going to angle the posterior implants. Are we going to do an all-on-6 or an all-on-X protocol? All this can be determined once we've had the digital tooth set up, because now we looked at the final tooth design as our starting point, okay? And then we now can work back and figure out what available bone we have, how we're going to address that available bone, how we're going to address it surgically, okay? And how we're going to combine extractions, additive procedures, resective procedures, and simultaneous implant placement of multi-unit abutments, okay? And do a PIC scan where we're going to digitally scan the implants and their position to each other, because the technology of being able to do this has created a much better experience for our patients and a unique situation that we're providing to our patient population at TCDM. So we're really working with this digital team in creating this protocol. And one of my responsibilities is really to create this digital workflow where I work with Sunil and the digital team in taking those data sets and merging them, taking the cone beam and taking the Trio scan and taking those digital files and DICOM data and to create what's called digital workflow. And from that, once we can do that, we've created our digital design, we can start to look at where we're going to consider implant placement. Okay, so as you look at in the prototype here on an all-on-4 design, we'll angle the posterior implants because we want to increase the AP spread, the anterior posterior spread. Because as you angulate the implants, and studies shown that angled implants have the same success rate as parallel implants, okay? But the angulating of the implants allow to, in the maxillary arch, to avoid any of the sinus procedures or sinus grafting, and in the mandible to place implants in the anterior mandible in front of the inferior alveolar nerve from mental to mental, and angle the two posterior implants so we can gain more tooth length. Because in the original anterior posterior spread design, the two parallel anterior implants, the line drawn parallel from the two anterior implants to the two posterior implants times 1.5 is the maximum amount of cantilever effect, okay? Well, it may not be an exact number, it's how we design. And digitally, we can design this amount of cantilever effect and increase anterior spread by changing the position of the implants in the digital workflow. Because as we change the angulation, the position, the depth of the implants, we may not be changing what our prototype bridge will be, but we will be strengthening our anterior posterior spread. Because in all these cases, we're analyzing these implant placement with ISQ, implant stability quotient. And as you know, from the Sorensen articles on ISQ, there's the implant stability initially is Black & Decker dentistry, okay? It's going to Home Depot and going to Lowe's and taking a screw and taking a drill and putting it into a wall or put it into bone. It is initially a mechanical process. Over a period of time, in the next 2 weeks, that bone will start to resorb and be replaced by new bone. Okay, so there's a window of opportunity where you can do this kind of digital dentistry without affecting the process of osseointegration or the stability of the implant. But we know that we have a certain amount of height of ISQ value, which is quantifiable, and we do it on every of our prototypes. If we don't reach a certain amount of greater than 60 on our ISQ, which is it's called an RAF, a resonance analysis frequency. If we don't have a certain amount of ISQ value, we don't immediately load these, okay? Then we'll consider a denture, okay? Patients know this in advance, and we prepare for this, because I'll tell Alan in advance, looking at this cone beam, that the quality of the bone might be type 3 or type 4, and we need to prepare ourselves, because all the digital dentistry is great, but it doesn't replace skill set and basic science and technology. You need to have the basic principles to apply it to the digital dentistry. So you can't take that specialty subset unless you have the basic science under pat, okay? And when we take that design and go towards placing these protocols, then we can start to create the digital workflow and create what's called a static guide, okay? And we're going to talk about how AI affects this in about a minute or so. But right now, most of the guides that we do and all the guides that we do at TCDM are called static guides, which means they're either anchored to the other teeth, they're not in real time, okay? Or they're using screws, they will be screwed in. If the patient's totally edentulous, then we'll do what's called a dual scan protocol, and then we'll create a guide that gets anchored into the bone at various points. And as you see in the guide on the left, it's a bone anchoring guide that's anchored into the jaw. And whether you do that flaplessly or not flaplessly is not a conversation I want to have now, but that's really, you know, a determinate in advance. And then I'll know if I have to do a flap or not. And then this guide is going through a series of drills till we replace the implants, okay? The technology for AI is now changing because now we are considering the infancy of dynamic navigational surgery. So right now, the two companies that are doing a lot of this is Navident and Clarident. And what we're doing is we're doing trace representation, and we're doing trace registration, where we're going to take 6 points in a patient's mouth and we're going to scan them. And we're going to take that scan and we're going to send, and we're going to merge that with the CBCT, and then we're going to verify those 6 points on the computer screen. And if the scanning 6 points that we've taken match exactly the scanning 6 points on the computer screen, we'll merge it with the CBCT. That data set will allow us to now do, with artificial intelligence, navigational surgery in real time, okay? It's the Da Vinci surgery for dentistry, okay? And AI is a very big part of being able to take that 6 data points and guide it through by using the information that is given to the computer system through the CBCT to give you guided surgery in real time, okay? It's like playing submarine. You know, it's a digital, you know, I have a gaming computer in my office to do all these digital workflows. And yeah, sometimes I want to play gaming on it because it's, you know, I like submarine. I'm still from the 80s and I still have Mario Brothers, which is now hot again. But that technology is not just the future, it's the present. And so that's what our goal is, to take this information and change it from a static environment to real time. And that's where AI has really changed surgical protocols for us at TCDM. Okay.
All right, thank you so much for a wonderful presentation. This is awesome. I'm going to quickly officially introduce you, Dr. Rubin. So Dr. Jay Rubin is the Director of Implant Dentistry and a Clinical Assistant Professor of Dental Medicine at the Toro College of Dental Medicine. He is board certified in periodontology as well as dental implant surgery. Dr. Rubin is certified in the pinhole surgical technique and the laser-assisted new attachment procedure, the only FDA-cleared laser treatment for periodontal disease. He has lectured for various hospitals, residency programs, implant companies, and dental meetings. So sorry for a little bit of a late introduction, but thank you so much.
All good. It's all good. Okay.
And I am now going to introduce Mr. Sunny Abraham, who's been answering a lot of our questions in the chat. So thank you so much. Mr. Sunny Abraham currently serves as the Digital Technology Administrator at Toro College of Dental Medicine and the Chief Technology Officer at the CAD Pro Academy. He has expertise in CAD/CAM and has worked with the Durham Dental Studio for many years. So we're now going to transition into the panel portion of our presentation. We have about 5 minutes or so left. I know that we've received some questions in the chat and also some direct private messages, but if you have any questions now that you'd like to ask, you can either put your name in the chat or type your question into the chat and unmute yourself to ask the question. Thank you.
Don't all
No
ask at
questions.
once.
The first question that we had actually come up with together, myself, Annalie, and Abe, was about the digital dentistry integration into clinic operations at Toro. How integrated is it? For example, if you're doing a crown, are they all going to be like the 3D printed crowns versus more traditional styles? And do you think that a lot of clinic operations should be moving towards this new style of digital dentistry?
Yeah, most of the crowns that we produce, so in the school environment, you know, one of the best examples I can give is about impressioning, right? Everyone says that, you know, oh, you should only focus on digital impressioning. But, you know, digital scanning isn't really the focus of impressioning. Impressioning is impressioning, knowing what to record and how to record it. So how that applies to your question, about, digital integration at the school, the students still have to learn and still have to be very familiar with the techniques of digital impressioning. So whether we do analog impressions or we do digital impressions, all of those need to be made available to all of the students there. And part of that process means that students have the ability to use and learn each of those different techniques. So what we are lately bringing online at the school are the 3D printers and milling machines to be used for same-day dentistry in the clinics. But the students have their option of choosing which technology they want to learn with at the time.
I also want to add to that is that, we teach in the second semester, about 13 hours. I'm the course director for that class. It's called Intro to Implant Dentistry and Surgery. We probably spend half the time, of those 13 hours, half the time in surgery and half the time in prosthetics. And we teach both components of it. Digital dentistry and conventional dentistry. We teach the history of it all. And I think the students get to learn both components, but as, an example would be is amalgam. It's a restorative material, but I don't know if we still have it at TCDM. We probably still teach it, but we don't use it on a daily basis in a clinic. So we want to teach the students the knowledge of understanding where dentistry has come from and understand how to use conventional, let's say, impression versus digital impression, or conventional bridge fabrication versus digital impression. You need to learn both to understand how to choose one over the other. You need to have a certain amount of knowledge in both fields to understand how to choose one versus the other.
Absolutely.
Great, thank you. Oh, sorry.
So we had a couple of questions in the chat. So one of them was from Kenneth, are there special techniques for scanning edentulous regions? So Kenneth, yeah, there are special techniques for scanning edentulous regions. You can do it intraorally. There's ways to do it. Of course, you would turn AI scan off because it's intentionally trying not to capture the tissue, but it's a little bit different of a technique as opposed to regular scanning, as you're starting from the palate out. And then for the edentulous ridge, lower mandibular ridge, you're basically just doing a U technique all around the ridge. Another technique is it's not always about scanning everything intraorally digitally, like Dr. Duran would say. You can snap a quick alginate and then scan that alginate in as well. So this way you can get, border molding and tissue done if you were doing it for a denture.
Right. And also scanning an edentulous maxilla is very different than a mandible. There's more landmarks in the maxilla, which will give you a better scan than in the mandible, which is just a lot of tissue. You're going to get a lot of scatter.
Yeah, definitely. One of the most important things I've learned with edentulous scanning is to evaluate the patient and say, this is a patient that I would scan intraorally. As Sunny mentioned with taking a quick alginate and scanning the alginate, the amount of attached tissue that the patient has is one of the big factors in determining, is this a patient we should scan? Or is it simpler for us to snap an alginate and scan the alginate versus sitting there for 30 minutes in the mouth trying to build the scan where the technology might not be the easiest way of capturing that patient? Our goal is to digitize the patient as soon as possible, not to always scan everything in the mouth if we say that.
Awesome, thank you. So we are almost out of time. I think we'll do one more question that was privately messaged, and then we will close for the night. So one of the questions was, what do you think has been the most important recent advancement in dental technology, and what area of dentistry do you believe would benefit most from advancements that still use traditional techniques?
Who wants to field that one?
Well, I'll say something quick. I think the digital workflow has really changed implant dentistry. It's really changed how, it's terrible to say this, how it's simplified patient care. It's just for the patient who has to go through so many endeavors previously to get to the point of doing a full arch of implants is dramatically changed. It's just become such a better patient experience that understanding the technology. You know, the goal of surgery is not to be the most painful and the most invasive. The goal is to be the most beneficial with the least invasiveness for the patient. And I think that's what it's given us.
I think if I could add in, you know, probably the most important part of digital dentistry, in my opinion, is how we can align data, right? What is the one thing that can be done digitally that really can't be done with analog dentistry? And the fact is, the more information that we can align, the more we can learn from that information, which then we can use hopefully in those other aspects of trying to influence our patient care and our decision-making process. So, you know, I don't even really consider myself a digital dentist. I like to call myself a digital alignment specialist, because really it's all about aligning data. The more data you align, the more information you get from it. And then the more you can use that data for practical applications to, in this case, improve our patient care. So that's what I think, hands down, is the most important part of digital dentistry.
Yeah, I'm going to use that phrase to haunt you for the rest of the day.
So am I.
What? I'm good.
I just have.
Go ahead.
I just have one question from Dr. Rubin. So, Dr. Rubin, does this mean that using a guide is always indicated for implants?
I think you were muted. I apologize for that. You know, Sunni knows. There's no monkey business. You know what, Alan, you know what the one thing I really thought about it just now is that the ability to share information with other practitioners has changed the digital world. Yeah. You know, the era of taking x-rays, mailing them out, waiting for them to come back, you know, waiting for your scan to come from the radiologist, you know, by UPS truck, you know, the access to information and patient sharing information has changed the experience for the patient.
Yeah, that's also been huge for us here at the school, especially with, you know, COVID now. You know, right. People that have never used a computer before now are all know how to jump on Zoom. So there have been situations where if we did have, you know, a quick fire that we needed to put out, I called Dr. Rubin, he's in his office in Brooklyn, we'll jump on right away remotely. He'll see exactly what I'm seeing on the screen. So from a lab perspective, collaboration has been huge, because even if he has a patient in the chair, he could give us a call, we can remote in and just make sure that he acquired all the data we need, so that this way there's less patient visits, less frustration overall.
Yeah, that's really true. That's really what's become great about TCDM is this, we're sinfully having a good time together.
So we could pay you less.
No, I was thinking of doubling myself. And that I'm not joking.
On that note, I think we will wrap it up for the night. So thank you, Dr. Rubin, Dr. Durham, Dr. Cho, Dr. Connolly, Mr. Sunil, for being here with us, for doing this presentation. It was very informative, and I think everyone had a great time listening. So thank you so much again, and everyone have a great night.
Good night, everybody.